Good morning, everyone. Welcome to Pediatric Grand Rounds today. Thank you for joining us online and in person. Our speaker today is Dr. Cesar Bravo from the Department of Orthopaedics. Dr. Bravo is an accomplished hand and upper extremity surgeon with extensive experience in pediatric orthopedic surgery. He received his MD from the University of Puerto Rico School of Medicine and completed his orthopedic surgery training at the same institution with his hand surgery fellowship at the Mayo Clinic in Rochester. He serves as a program director for the Genutech Carilion Hand Surgery Fellowship since 2019 and oversees the training of the next generation of hand surgeons. He's board certified in both orthopedic surgery and surgery of the hand by the American Board of Orthopedic Surgery, with active participation and maintenance of certification. He holds memberships in the American Academy of Orthopedic Surgeons, American Society for Surgery of the Hand, American Shoulder and Elbow Society, and the American Association for Hand Surgery. He maintains an active practice, very active, recently with sledding at Carilion in Iron, and he's been practiced since 2005. Please join me in welcoming Dr. Cesar Bravo.
Well, thank you for having me and good morning. Definitely is always an honor to come and just share some knowledge, some information. You guys do so much for us, so we really are in gratitude when we can give back. And I have 5 kids, and you guys have taken care of my 5 kids all throughout, so I'm indebted to all the care that you guys provide. So my charge today is definitely, I'm going to talk about pediatric shoulder and elbow injuries, and the way that I've broken down is just common elbow injuries that we see and common pediatric shoulder injuries, but we'll do a kind of case basis and kind of, in a sense, for you guys, what are important things to see that you'll see in your walk-in clinics, and then know when to refer and when to say, look, we can just manage or just kind of counsel the family. And then we get into a little bit of athletic endeavors and different athletic injuries that you'll see in your clinical practice and how to manage and things that we usually are telling our pediatric population that you guys can also share as well. You can gather some information from that. So our learning objectives, we want to basically recognize what are the common shoulder and elbow injuries that we see in children and adolescents, and be able to perform focus exams, so like appropriate first-line imaging, because you guys are the first line of people that they intend to see. It's not always coming directly to an orthopedic clinic or to an urgent care clinic. And we talk a little bit about evidence-based management, identify when to refer urgently, when to just pick up the phone of the perfect serve and just let us know. And then in a way of what questions families may have and that you may counsel them and kind of, especially with sports-related overuse injuries, which we tend to see a lot as well. And what are pediatric injuries and why are they different? Well, the pediatric bone is definitely, the injuries tend to be more through the physis, which the growth place is what we refer to as the physis, and they're usually weaker than the surrounding bone. So when you have an injury, in a sense, you'll have an injury which is here showing the growth plate or the physis, which usually looks like a black line in x-rays. And this is usually the weaker point, and this is what tends to get injured. The younger the patient, the more active that growth plate is, and the more likelihood that they can injure it, but also the more likelihood that they can remodel. As they get older, the less likelihood of remodeling, and sometimes intervention in the sense of just close treatment is more indicated. And we'll refer to this, and we'll talk a little bit about toddlers injury that we tend to see a lot. It was known as nursemaid's elbow. We'll talk a little bit about school-aged children's falls from height, and teen with sports throwing contact injuries, sledding injuries, all those things, and we'll kind of mention 3 specific pathology. But a little bit, when we ever talk about pediatric injuries, we talk about the Salter-Harris classification. You guys just need to be aware of that. That is based with regards to the injury that you have to the growth plate. So when we talk about it, we're using an ankle as an example here, but you have the growth plate here, and when we're talking about a growth plate type 1, it's just the injuries within the growth plate. When it's a type 2, it tends to go away from the joint line, and a type 3 goes into the joint and it gets up to the 0.5 where basically the growth plate is totally smashed. And each joint that has a growth plate with an articular surface, albeit be it the ankle that we were showing here, but the shoulder the wrist, the elbow. This is what we refer to as Salter-Harris. And the thing is, the higher the injury mechanism, the more involvement of the growth plate, the severity of the injury is much higher, the likelihood that it can injure the growth plate is significant. But a little bit about the growth plate. It's pretty incredible how our bodies are built. And if you think of the growth plate, it's actually an area where it's actually lined up in layers. So there's multiple layers within that growth plate. And think of it as the first layer is we call it the resting zone. That's when the bone cells start as cartilage. It's like the little babies, the chondrocytes. And there's the second layer, which is the peripherous zone, which these little babies start reproducing and become like gremlins, and they start, increasing in size. And you have the zone of hypertrophy, which is the next layer, which is starting to be getting big. These is when the chondrocytes start to get larger. You can go up to 10, 15 times in size. This zone of hypertrophy is usually when we have fracture, it tends to injure this zone of hypertrophy. And then as we get older, these zone of calcification becomes more pronounced, and then eventually it ossifies, and that's when that cartilage becomes bone. So then eventually you get 16, 17-year-old, you do an x-ray, the growth plate actually, it's basically closed. But they're predisposed to injury, and this is what we tend to see and what we want to treat early. Identify it, treat it, and manage it. And if you look, we're talking about the elbow and the shoulder today, but if you see as we start in 1-year-old, a lot of it is all cartilage. So this we won't see specifically in x-ray when they're injured. As you see these areas here, these are the ossification centers. They start to calcify these layers or become to a full bone, especially when they're, articular cartilage. Basically, the cartilage itself becomes bone. The shoulder is the same thing. These are dots right here are the ossification centers, start as cartilage and then eventually become ossified. The biggest thing is these do contribute to not only to growth in the length of the extremity, but also in the girth and the width. The shoulder is about 80% of the length of the growth of the arm, 80% comes from the shoulder physis. So an injury to the shoulder later within that physis that can disturb, can lead to disturbing of the injury, of the fracture site, of the growth, but it also has a lot of remodeling potential. So let's, the case one, this is typically what we refer to as nursemaid's elbow. And usually these toddlers, you'll see them, and they're, what we want to get with the history and what the parents will report is, look, we were pulling on the elbow and it kind of felt like they wouldn't move and they kind of stopped. Usually we want to advise the parents not to really pull on the pediatric patient's arm or swing them from their wrist, or sometimes they're pulling, you don't want to pull away, because what happens is this area, which is called the annular ligament, is fairly thick, and when in the taller age, it's fairly mobile and it can get entrapped in the joint. And that's when they suddenly don't move it and they kind of stuck and they think, oh, there's an elbow dislocation, they've got fracture, but it's actually that tissue. And the way to put it back in place is to hyperpronate, because it kind of pulls it away. And we used to be taught to supinate and flex, but usually it's the hyperpronation. They'll kind of self-reduce, and we don't have to mobilize them. We don't have to hold them. They'll kind of self-reduce and then start using it. But it's also to be aware and then get the history with the mechanism as well, because usually the parents said, oh, I was just pulling on the arm, so we're moving, and then the child gets scared. And so those are things that we'll see commonly. But if you can identify it, then you can advise. I think it's something that you can definitely manage effectively, but you'll see it in your practice. The other one that you'll hear about and you're talking about is the supracondylar fracture of the elbow. Of all the elbow fractures, 50% of them are supracondylar fractures. And for us, this is bread and butter upper extremity surgery. We see this day in, day out. If you go at Memorial, every other morning, these are coming in and they're being treated. A lot of them do require surgery, not all of them. And what we want to identify is that when you see this in your clinic, if it shows up in your walk-in clinic, is document the neurovascular exam, check their pulses, look at motor and sensory exam, because these can have issues with it. These fractures do tend to heal in a malunited position if they're not reduced. And one thing to look into the x-ray is looking at the posterior fat pad sign, which I'll show you what that looks like in x-ray, because when you have that 95% of them will have a subcondylar fracture. The thing is, we do grade them with regards to severity, and I'll show you a couple of pictures, but this is the type of history mechanism that you see that the parents say, look, they're on the monkey bars and they kind of fell backwards. And what happens is they hyperextend. That olecranon kind of hits into this hyperextension mechanism, and this is the weak part, or what we call the supracondylar level, or where of the distal humerus, and this is where the fracture takes place. It presents in different varied ways. It can be where it's fairly displaced to the front or displaced to the back, and that's when we call an extension type or flexion type. But what you want to identify, if you look at this elbow, it's a basically immature elbow. In a sense, it actually looks like there's not necessarily a fracture line, but there is right here. The thing to look is for the fat pass. Normally, we have an anterior fat pad, which is a normal finding. Once we have a fracture, there's some bleeding into it, the capsule expands, and that's when you have the fat pass sign. So usually for a type 1, which we would say would be one like this, that's not on displaced, it's like not as displaced as is shown in the bottom, those we can immobilize for a cast, and we immobilize them for 3 weeks, and we don't even x-ray after the 3 weeks because 98% of them do heal without any issues, and they'll start using it. So we're pretty aggressive on treating those. Once you get to more displacement on these supracondylar fractures, be that it's a type 2, a type 3, those we tend to fix, and we're pretty aggressive at our institution in treating the type 2s because close treatment in a subset of them do shift, and that's when they have the deformities that they'll have what we call the cubitus varus, or like a gun-stuck deformity when they heal with their arm, or when they hyperextend because it hasn't healed properly. The elbow, when they basically straighten the arm out, goes all the way up. So that's a residual from a myelin supracondylar fracture at times. Always the vascular assessment is important to document. That's what we tell our residents, and and as we're documenting, because sometimes it's not even documented when they're referred, that does change it from more of an urgency than into an emergency. And red flags, any absent pulses, and usually we tend to see this in severity. Hopefully they're not showing in your clinic right off the bat with a severe injury, but those are things that we teach and we want to look for, especially for this type of injury, supracondylar fractures. Then, in addition, another common one that you'll see is that presents with elbow pain on the outside lateral elbow pain is lateral condylar fracture. This one's different than the supracondylar fracture in the sense that it actually involves the joint, the articular surface. And it's often pretty subtle in x-rays. The kid will actually be using it, it'll present with subtle swelling in the outside of the elbow. And the thing is, for those, when you see that, you immobilize, get an x-ray, and then refer, because these we tend to immobilize much longer. And again, the injury mechanism is still on the outside of the elbow, like shown in the previous picture, but it's on the lateral side. And what happens here is what you're seeing on x-ray is basically at the tip of the iceberg, because it's an articular injury basically that goes all the way into the joint. So what we're seeing only in x-ray is this part right here. So if you were to look apart in this here, you're just seeing this part here, but it's actually the fracture line goes all the way through. It's a pretty big piece that's actually involved. And again, it involves the articulation, so a malunion early on will lead to problems, and they can also go into non-unions if it's not immobilized properly. And that other, from the lateral side, will go to the medial side. With the medial side, you'll also see in what we call little Leger's elbow, because that's where you have a lot of the collateral ligaments on the medial side tend to get injured. And what you can have here, instead of symptoms of the vascular injury and some of the nerve injuries, is very characteristic of having maybe an ulnar nerve type issue or irritation, and avulsion of that apophysis, which is the outside top part of the articular surface of the distal humerus. The biggest thing is that you can have ligament injuries. It can be where, for example, this is the ligament. You can have what we call an intrasubstance tear, which is in the middle. For these type of injuries, medial condylar fractures, it's more an avulsion type injury where the ligament doesn't actually tear, but it kind of goes from up that root of avulsion, or what we call an avulsion type injury. Again, this is from the, now we're moving into the inside, which is medial epicondyle. And you can actually see here that the ligaments, this is what in adults, when we do repair for Tommy John surgery or ulnar collateral in pictures, that's the ligament we're repairing. And if you can see, it's pretty intricate with regards to the ulnar nerve as well. And the injury tends to be in the area of growth, or what we call the apophysis, because it's not in the main articular surface here, and it's more of an avulsion type injury like shown in the picture. And this is something that, because it's already in the apophysis, it's not right in the joint. A lot of these, if they're not symptomatic, even though they look really displaced in x-rays, a lot of them we treat them without surgery, and they tend to do fine, and they don't have as much deformity because the contribution of growth of that apophysis doesn't tend to be as great as when the other injuries, like in the lateral condyle fracture, in a sense. So sometimes you'll see, and the data has swung. When I was a resident, we would fix them all. Now, I guess I'm a little older, being on practice, I've seen the pendulum swing to we're not always fixing these with surgery, unless they do have nerve symptoms, they're displacing the joint, which is something to consider. So with elbow trauma, we've seen a couple of the common pathologies that you guys will see. Always look for that abnormal neurovascular exam and really look for that. If you see any growth deformity outside this in the skin or growth displacement on x-rays, those are urgent referrals. Severe pain and swelling, unable to cooperate with the exam, that's usually the child be fairly anxious. Those are for you guys to be aware, kind of put what we tell our residents with your spidey sense. Lateral medial condyle fractures, any displacement, or even if a history of dislocation, as when in doubt, it's easier to refer, and any inability to obtain a reliable exam. But the biggest thing is you'll see them, elbow pain, take a look at the x-rays, and because you guys will do in the initial triage. But when in doubt, splint and refer, and if you are not able to get in, just a direct call to any of us. We would always have, there's always someone available to see the patient. We just need to know. And sometimes we don't get communication directly, so it's not that we wouldn't see them. So any questions with the elbow as before we move to the shoulder part? Okay. So as we go to the shoulder, which I think is also pretty fascinating, one of the most common ones that you'll see is the clavicle fracture. Usually this is the 7-year-old with shoulder pain, have a visible bump after a bicycle fall. It's one of the most common shoulder injuries. It usually is in the middle, what we refer to as the mid shaft. And the thing is, it has an incredible remodeling potential. And I'll show you an x-ray that really shows that. The key exam is looking for skin tenting. In our shoulder area, especially the part of the clavicle that makes the part of the shoulder, has what we call the delta trapezial sleeve. So there's a lot of muscles around that area. So if you think about it, in the front part, it's fairly thin, but in order for it to be propped enough, it tends the skin, and I'll show you a picture of that. That has to be basically torn. So the injury is a fairly high mechanism of injury. So when we see skin tenting with clavicles, that kind of does change the management in the sense that it's something that we watch carefully, and sometimes we may need to treat because it can compromise the skin and can lead to an open fracture. One of the things is with the clavicle, it really has significant remodeling potential. So, and usually we tend to see in 14, 15-year-olds and still remodels. You say, whoa, what's going on? There's a lot of shortening here. It's basically displaced, but look at that remodeling potential. And this actually tends to heal pretty remarkably, and the shoulder function is not necessarily completely affected. So they do well with non-surgical management. Unless, again, you have that skin tenting, which is what we'll show a picture of. But our management in this mid-shaft, in our recent literature within adolescents and teenagers, we tend to treat them a lot. We used to fix. There was a vogue time that we did, but now definitely it's a close treatment. Unless specifically you see that skin tenting, this is where the boning piece has gone far enough that it's actually gone through the muscle fascial sleeve, and then you have the blanched skin, the bruising, and that can lead to an open fracture. So some of these, when in this case, we tend to address them surgically. And the biggest thing is understanding you have a lot of pulling forces here. You have your trapezius, your deltoid, your pectoralis, there's subclavian vessels right behind. So for these, also document the ulnar nerve exam because the medial cord is actually within that area. So it's, if it's a high energy impact mechanism, those are things to consider. But this is something that can be testable for our residents. When they'll see that, that's more of an urgent referral in that aspect. As we move to the proximal humerus, which usually we tend to see this more in 13, 14, 15-year-olds, and what happens is they'll have an injury into their growth plate. The growth plate in the proximal humerus is like a chevron type shape, and it has a pretty massive remodeling potential. And we say that because it does contribute to 80% of that longitudinal growth of the shoulder. Again, older adolescents may need more aggressive reduction than the younger patient in the 12, 13. And the key teaching point is basically the displaced fracture can still heal with conservative care. And I'll show you an x-ray of that progression because it's pretty remarkable what the body's able to do. For these, initial treatment is sling supportive care. We do follow them regularly enough. Again, we have a reduction or unstable alignment. we'll do x-ray every 7 to 10 days until it gets to the point that it's sticking, or what we say the 3-4 week period, and then the long-term follow-up within those, after that 3-4 week period is not uncommon. You don't always have to x-ray after that period if they're clinically doing well. The biggest thing is, in addition to the growth plate being so active and the remodeling potential, is the amount of injury that you can have and that lead to displacement, because you have so many deforming forces along the proximal humerus. You have the subscapularis, which is a part of the rotator cuff from the front part, the supraspinatus, which is the top part of the rotator cuff, and the infraspinatus, which is the back side of the rotator cuff. So all those three muscles that come together form that big tendon, what's called the rotator cuff. They all are pulling in different directions and lead to displacement. And then you have the pectoralis major, which is the muscle right here on the front, pulling on the arm. So it can lead to a lot of deformity. So this is a typical patient that we get called. We see them, they were, riding their bike, they fell, or horse riding, riding their horse, and have this injury. And you go, whoa, this is really separated this place. But look at the remodeling potential after a month in just a sling. So if we have bony continuity, bony alignment, and they're fairly young, it's pretty remarkable what the body does. And then this is right here is over at 6 months. So the remodeling potential. And the thing is, we have some of these x-rays in our office, because parents will see that x-ray, see that amount of x-ray, and they're going, oh my gosh, what, are you going to leave my kid like that? This is not going to, and we are, no, look, this will remodel. And sometimes it's actually harder for us to treat it, because you're sequentially telling them it's going to be fine, it's going to be fine. And they're seeing that progression, and for them to see it, because we normally see it day in, day out, but they don't know the end result. And that's where really the advice and kind of the guidance and the treatment that we provide really does settle the parents, because sometimes that's one, the kid usually won't be painful. They'll have a terrible looking x-ray, but they won't be having any pain. And so that's where it really becomes challenging at times. But it's part of the process, but it's pretty remarkable, the remodeling potential. One of the other ones that we have is the anterior dislocation, and I do bring in this case presentation because this is usually the 14, 15-year-old, either volleyball player, football player, and usually they tend to dislocate anteriorly, and which we refer to here. This is anteriorly dislocation, which is with regards to the coracoid process, posteriorly into the back, but the anterior dislocation is the most common. The biggest thing is that if you see it in adolescents, for you guys to identify, the risk of recurrent dislocations in a young patient is fairly high. So those are patients that we follow closely, we manage, because of the high risk of recurrence. So it is much easier if you have a shoulder dislocation. Let's say I would have a shoulder dislocation. My likelihood of me having a recurrent dislocation compared to a younger patient is much less. I'm more likely to have a rotator cuff injury with my shoulder dislocation that may need to be addressed. But the recurrent instability pattern, you'll see it in adolescents, and that's why you high-level athletes in their 20s, NCAA, that have these dislocations, those are really significant injuries because they'll have issues all throughout into their 40s and 50s. So for you guys, it's something to know. That's a key teaching point, that our first dislocation needs also consult, and for us to at least see that patient early on and do that referral so we can then, follow the patient closely. The other one that we see a lot in our clinics is what we call the lateral shoulder. And basically this is it's a stress injury to the physis. We call it a proximal humerus epiphyseal. It's more of an overuse injury. And if you see, when you do an x-ray on a proximal humerus, again, that chevron type growth plate, you can see the widening here. This is the typical lateral shoulder where that physis is hangry, it's trying to remodel. And this is how it normally should look. You should not see this much widening in that space. For these, the key is rest. And it's advising the parents, and advising the patient, but usually it's the parents, because these kids are on travel ball, they're doing a certain insane amount of throwing, and it's not necessarily a surgical emergency, but it can get to that point if they don't manage and modify. And for us, it's complete rest from throwing. You want to do gradual return to sport. You address the workload, meaning for us, that means pitch counts. If they're, throwing athlete, limits the innings, taking an off-season break. That's actually a good thing. because this is one of the things that you guys will see very commonly. And it's the same thing, not only for the shoulder, but you'll see it in the medial elbow, in the pitcher or overhead athlete, that you'll see these organs injuries.
Cesar, for the anterior dislocation of the shoulder,
Yes.
is that reduced by itself?
A subset of them do, and they kind of fall into place. And the thing is, if that's where to start happening, that may be a patient that may develop, we call multidirectional instability, that are hyperlax. So that's a different pattern in the ones that actually dislocate and self-reduce, and the traumatic one, the one with a higher recurrence rate.
And do we try to reduce that if we see it, or just send them to the?
I would send them, because if you don't have the sedation and all those things, but usually, yeah, if you think of it, then, and if you can't do what we call a true axillary view, which is where you put that, just do an x-ray, and then you can ask them to do a scapular wide view with the arm at the side, and you can actually tell. But if they're in doubt, don't pull it, just say it, because we have the means, and sometimes if they require more sedation, different things, but at least identify, and sometimes you just see where it's already been reduced, and they'll follow with the pediatrician instead of the orthopedic surgeon, and that's more likely the scenario that you'll see. And at that time, do the referral, because at least there's a documented follow-up within the orthopedic and upper extremity or piece ortho as well.
All right, I have to ask, is that what Mel Gibson has?
Mel Gibson?
Wait, don't you know the movie where he pulls his arm out of joint?
Yes, yeah, Braveheart.
Is that it? Is it? No, it's what, I know which one you're talking about. I can't
I
think of
thought it was Lethal Weapon or
Yeah,
something.
lethal weapon. He gets out a straight jacket.
Yeah. Okay, sure. I thought for sure.
That's good. So the biggest thing, counseling for young patients, avoiding single sport year-round specialization is really good. Follow age-appropriate counts, especially for throwing athletes. And I think an off-season rest is actually a good thing. I'll tell parents, and I'm at fault that is just 3 months a year is good for our kids to kind of rest for a little bit. And the biggest thing is for you guys is understanding that pain is not necessarily normal. Address if the pain continues, and then also advising proper warm-up, cool-down, strength and flexibility training. We're pretty big about core strengthening our young athletes because it's so protective to other things that they do with their upper extremity. So a lot of the rehab is not only the extremity, but also the core strengthening. Pretty remarkable in what you're able to prevent. Again, just to kind of review from our cases of supraglottal fractures, the most common elbow fracture, about 50% of them will be supraglottal fractures. Again, looking at the neurovascular injury, the clavicle, simple arm sling, referral is adequate after, and then the referral, but definitely a high propensity to remodel, as well as the proximal humerus. With the proximal humerus, you'd be mindful of knowing if there's a history of dislocation. The nursemaid's elbow, not necessarily, you don't really need to put them in a cast or immobilized. Sometimes I've had patients with nursemaid being immobilized from a long arm cast and referred to our clinic. So that's something that we don't have to be doing. And then always follow up, appointments. You guys know this elevation, and the biggest thing is for pediatric patients with upper extremity injuries. If you're thinking something we hear about compartment syndrome, you guys know what that is. Usually in adults, it's severe pain, progressive tightness. In kids, we say usually it's the 3 A's. It's analgesia, anxiety, agitation. They'll be very anxious, and they'll be very fidgety, and they'll be asking for pain medication. Usually that they don't ask for pain medication. So those are things for us to be aware as we treat these injuries. Again, just for review, neurovascular exam, absent pulses, any of that sort, obviously urgent referral. A lot of deformity that you see, any gross displacement or a lot of swelling, those are fracture until proven otherwise, that you refer. And the severe pain, even with a normal x-ray. And that may be the physis injury that we talked about. And those are things that are subtle that adequate immobilization might be indicated, especially in the younger patient, and to treat it early than in a delayed fashion. And then again, the compartment sign syndromes for an extremity, looking for instead of the P's in adult, the 3 A's. And
I know for the apologize for the neurovascular compartment. We're getting them to you immediately.
Yeah.
But for some of these other things, what kind of timeline are we looking at to getting them to an ortho referral? Like if we're out in the middle of nowhere and we need to get them up here or something, what kind of timeline are we?
Yeah, within the timeline, I would say within 3 to 5 days.
3 to 5
Yeah.
days.
And that's not unreasonable to send that referral because we have people within our, each of us is assigned every day to review some of those referrals coming in. So we'll take a look at the x-rays and some of those we'll pick up if we need to see sooner. But at least putting that timeline is not unreasonable. And especially if enough of concern and you're seeing it, that's the right thing to do. And that's what we do. I mean, that's what we're here. I mean, so yeah. And again, though, the biggest thing is that I would say, look, if there's any doubt more of concern, you put that referral, but if you don't think it's getting managed accordingly, just reach out to the person on call because we have somebody on call for acute injuries 24/7. And they'll also direct traffic. So if it's something that whoever's on call that day doesn't necessarily manage, but they have the duty to actually get them to the right person to get managed. Yeah. And sometimes it may be our mid-level providers, but they work with us 24/7, and that's just an access to that door, but they'll be starting the management process. Key takeaways, always document and that elbow exam. Treat that painful elbow, especially if that's swelling until proven otherwise is injured, fracture, or.
Probably the front door. I think so, because I'm going to bust my tail.
That's a different body part.
Take care of that.
Treat the painful elbow as swelling until proven otherwise. And again, the overuse injuries. And when in doubt, immobilize and referring. And again, you guys are busy. You guys do so much. Whatever you guys need from us, just reach out because you guys provide us a big patient population that we treat and care for. So that's what I had, and this is our whole and upper extremity section. Okay.
Make a little announcement about the new person. The new person.
Yes, so for us, within our hand and upper extremity section, within Virginia Tech Orthopaedics, a lot of us do treat pediatric injuries and adolescents. We also have separate to our VTC hand and upper extremity, we have our Peds Ortho clinic, which is also, it's basically managed by Dr. Solinsky, Dr. Grace Blaylock, and we have a new addition to our team, Cody Smith, and he's a great guy, great addition to the team. In addition to us, I see him a lot in my practice, Dr. Apel also in our practice as well. So definitely, we have an open door for you guys and always reach out with questions and we're here to serve. And thank you for having me. It's definitely a pleasure.
Dr. Kreider I'm sorry. She said, we don't have any ortho glass or splinting material in my Gen Peds office. Suggestions on splinting elbows in our setting.
Yes, so if you don't, maybe we can try to arrange to get some of those. If you were to have, at least it's always good if you're seeing some acute injuries to triage, and then you can have some ortho glass, and we can get our cast technicians that we have to help you set that up and kind of provide that. And we can have them also do some instructions in some of those things and provide that.
And we had, maybe it's not applicable to arm, but we had a hard time getting crutches. We don't have any in our building, and it was difficult to get it done, like send them somewhere to get it. They pretty much had to go buy it themselves.
Yeah, so for those, I'll talk with basically our supervisor that does that and Team 4 does a lot of it for us. And we can see if that, because that would be, because you guys are seeing acute injuries as well, so that may not be unreasonable to have at hand. And that's something that can be provided. I don't know if there's the facility cost and how they kind of charge it and bill it, so that's something that gets a little bit into the weeds, but I think it's definitely something to look into. We can see if that can be provided.
You talked about after an injury, giving rest, mixing up sports activities, and you have some of these children on restrictions. It's a hard time for, I imagine, primary care folks to convince the family that they shouldn't return to whatever sport they injured. But also, is there a risk of injury doing some of the things they do commonly at home? These youngsters on virtual gaming and all that. You have to advise them about that.
There is, and that's a very good point. So some of the more repetitive type injuries that we see in the hand, especially overuse, like for the thumb, the index finger. There's a video game, I don't know the name, I listen to the name, but that they play, it's like they're like a monkey. There's a name for it, but they're walking around and they're doing that. So we've had where they've come with overuse of the shoulder and the elbow. So those are things in the history that's very important. And we advise them on that with regards to length of time that they use the devices. Because we do have some patients that are using that for 8 to 12 hours a day. Yeah. But we see a lot of overuse with the thumb, CMC swelling, that they'll even I'll have patients where they develop trigger thumb because of it. And so and then with the history, then they tell you, I just gained for 6 hours. And okay, yeah. So that's a very good point.
Does the brace help with that, or is it just pure?
The brace, we do mobilize and brace just to kind of keep them out of using it, but it's basically behavioral modification as much. And that it's a hard thing because that's also their social, or some of them is their socialization with other, so you don't necessarily, you kind of want to be mindful in how you're managing those things. But, yeah.
Is there anything you can do to help promote healing? Is there do you ever recommend vitamin D? Or?
Yes, we do. We do vitamin D, and pediatric, for adults, we do 50,000 units, 1 pill a week for 6 to 8 weeks. We do use it in adolescents, but it does get to the dosing. But definitely, we do check the vitamin D. It's not uncommon for me to see a wrist fracture and then get a baseline vitamin D because, especially for scaphoid fractures as well, because they'll be low. And what we're considering low is less than 40, not the 30 limit. It's for us, it's a 40 limit because our data shows that above 40, especially in adolescents, you want to have them above 40 once they have a fracture and they've got increased healing. And then definitely you can combine them with the calcium and modify, but it's not uncommon for us to do a level if we need to, or if not, we empirically treat it for 4 to 6 weeks with a mega dose. And the thing is, it's pretty tolerable. It's just they may have some stomach issues. Some may be pretty sensitive.
Thank you.
Thank you guys.